Hello, good afternoon. So we will be finishing up lecture 4 today, and hopefully we'll have some time to do some other stuff as well. Um, so we were talking about the upper respiratory tract last class, and sorry, let me just turn on the caption here. And that includes things like the nasal cavity, the pharynx, and the larynx. And then after the larynx, we're going to go into the lower respiratory tract, which is the topic for today. So here we go. Trachea. The trachea is also known as the windpipe, which basically connects the larynx to the main bronchi. And it is in front of and parallel to the esophagus. Right? Esophagus is the tube that carries food from the mouth to the stomach, and the airway is just in front of it. Now, we want to keep the airway open at all times, and that is why it is protected by these C-shaped cartilage rings. And you can actually, if you move your hand up and down, slowly in the neck area, you can feel the ridges of each of the cartilage rings. Last time when I show you the video of someone's vocal cord, you can also see the cartilage rings that are around the trachea. Now, the ring is not going to go around the entire trachea. It's just going to be C-shaped because, like I said, behind the trachea is the esophagus. So you don't really want a ring that goes all the way around and start constricting the esophagus as well. So that's why they're just going to be C-shaped. In terms of the inner lining of the trachea, it is covered by a layer of what's called pseudostratified ciliated columna. We actually learned this last semester, but let me just remind you what it means. First of all, columna means the cells are rectangular in shape, right? And they have cilia on it. That's why they're called ciliated. And then pseudostratify, pseudo means thick, right? And stratify means multiple layers. So pseudostratify means it appears to be multiple layers, but actually it is just a single layer. Okay, that's basically what it is. And also, there are another cell type called the goblet cells. And the goblet cells are there to produce mucus. These mucus will help trap the breaths, and the cilia is going to sweep these trapped debris up to the throat, to the pharynx, where you can spit them out or you can swallow them. So that's part of your physical barrier, right? This is what a cartoon looks like, and this is the real thing on the right side. And again, you can see the cilia over here, and these purple circles, those are nuclei. And you can see there are multiple layers of nuclei, right? Or so it seems, but actually it's just a single layer. It's just that the cells are kind of, squished. If you look at the cartoon drawing here, right, you can see some cells are kind of squished together like that, right? It gives the appearance of multiple layers, but in fact, it is just a single layer. And every now and then you have these goblet cells that would be there to secrete the mucus. Over here, we have a much more powerful microscope, a scanning electron microscope that can show you much more detail. You can see the goblet cells again here and there, and all these little carpet-looking things, those are the cilia. Okay, so together they work to prevent things from trapping in the airway. Now there's something called tracheostomy, which you might have seen on TV or something, right? Sometimes the person cannot breathe through the mouth or the nose because there's some trauma. There's too much blood pooling, and the in the pharynx, for example, and they cannot get the air in. So as an emergency measure, they might just create a hole right here, right, and insert a tube directly into the trachea. Right? So the person can be breathing through this tube, right? But afterwards, they would have to uh, 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 seal the hole and let it heal. And sometimes they don't heal completely, and there is a permanent hole there, and the person needs to cover the hole in order to be able to speak because the vocal cords are up here, right? So if there's a hole here, all the air would just escape when you try to speak. So by covering the hole, you can let the air go through the vocal cords and produce sound. Yeah, sometimes people have to do this for other reasons, like cancer, throat cancer, for example, right? And they would have to insert like a breathing tube this way. All right. Moving down, the trachea is going to branch into the bronchus. Now, I think it's better if we go back to the study guide here and just label some of these things together first, so that it makes a little bit more sense. You know what? I'm gonna do this diagram first. This one has what I'm looking for. So could you please take it out and find this page, and then we will color it together. Okay. So just simple stuff here. Over here we have the lyrics. And just to remind you, it is protected by thyroid cartilage. Now, there's another cartilage here. We labeled this last class. Okay, that's actually like a transition that goes to the trachea over there. And this is called the cricoid. Cricoid cartilage. Then we have the trachea, the airway. And you can see over here, right, these little lines over there. These are the C-shaped cartilage rings, right? Protected by cartilage. And again, it's parallel and in front of the esophagus. And what happens is it will branch into the left and right bronchus. So this one over here, that is the left bronchus. Sometimes they will say left primary or main bronchus. Whereas on the other side, we have the right primary bronchus. Also, you can call it main bronchus. The plural for bronchus is bronchi. Now this thing will continue to branch for a little bit. So it will split again into smaller ones. I know it's not on the diagram here, but these smaller ones, they are called secondary. Secondary bronchus. From the primary, they split into secondary, and you can see where this is going, right? It's going to split again. It's going to split again into even smaller ones, which would be called the tertiary bronchus. So this whole thing, right, like all these things, it's like an upside down tree with all the branches, right? So we call this the bronchial tree. It's like, again, like if you take a tree without the leaves and then you turn it upside down, that's what this looks like. Any questions? Now, the secondary bronchus are also protected by cartilage rings, but this time is not C-shape anymore. Right? It's like full ring that goes around because there's nothing behind it, right? But for the tertiary bronchus, it's getting too small to have the entire ring around it. So instead, they are protected by cartilage plates. So let me draw it out for you on the side here. Okay, so this would be like the zoom in of the tertiary bronchus, and then instead of having a ring that goes around it, you would just have like bits and pieces of cartilage. That just gives it a little bit of reinforcement. Okay. Now it will continue to branch a little bit and become like really, really small. Okay. So these really small ones, and these are called bronchioli. Sorry. Bronchioli. And they are very small, no cartilage, can collapse, especially like during asthma attack, they can collapse, and they are less than 1 millimeter in diameter. Very small. And then at the very end of the bronchiole, you would have these air sacs. They are called alveolus, which is the site for gas exchange. Okay, so I'm just gonna let you copy what you need first. Ask questions if you need to.
Vincent, can you hear me?
Hmm.
Okay, so I thought capillaries were the site for gas exchange.
Yes, so surrounding the alveolus are going to be like some capillaries, which I haven't drew in. Yeah, but
Okay.
I have a slide coming up for you. Very good. Okay. So getting the air into the lungs, that is going to be the uh, 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 inhalation exhalation process, right? And then when we get the air into the lungs and we need to get it into the blood, that's like external respiration. Okay, we talked about that last time. Okay, so that's that. Now C over here is nothing special. Okay, C is just the left lung, and then this is the right lung. That's all. Okay, that's it for now. Um, maybe we leave that for later, I suppose. Okay, let's go back to the PowerPoint slides. So here, now that we've labeled it, it should be easier to make out what's what. So over here, we have the primary bronchus. You can see the cartilage ring actually goes around the whole thing, right? And then it will split a couple times. You have the secondary here, secondary, right? Tertiary. And then once you get down to the tertiary, you have these little plates, right, that I was trying to tell you about. And then it further branches and becomes the bronchioles, and then we have the alveoli at the very end. Okay, I know it says lobule, but we'll just say alveoli. Alveoli is plural for alveolus. So the bronchioles, they are, like I said, less than 1 millimeter in diameter. They don't have cartilage support, but they still have cilia inside. Okay, the entire airway, the trachea, the primary, secondary, tertiary bronchi, and the bronchioles, they have all have cilia inside. Okay? And during an asthma attack, because the bronchioles don't have the cartilage, they will collapse. Right? We call this bronchial constriction. And when you constrict the airway along with the excess mucus secretion, it makes it very difficult to get air through it. So that creates these wheezing sound that you might hear when someone is having an asthma attack. Okay? So they need to have a vasodilator, and that's what the puffer is. The puffer helps the smooth muscles to relax in the airway and opens them up. At the end of each bronchiole is a cluster of air pockets called the alveoli. Again, that's where gas exchange occurs. So that's what the alveoli looks like. It's a cluster of air pockets, and surrounding the alveoli are the capillaries. These are pulmonary capillaries, right? Um, and in terms of the kind of tissue that makes up the alveoli, last semester at the end, I told you because we want gas to be able to cross them easily, the alveoli are made up of simple squamous epithelium. Simple means one layer, and squamous means flat. So these are just very thin cells, allows the gas to go through them without much trouble. So gas exchange occurs between the air and the alveoli, and then the blood in the capillary. Basically, oxygen goes into the blood, and carbon dioxide goes from the blood back into the alveoli. Okay. So I have a quick note to take for you. Let's go to a new page. There we go. Gas exchange. It's a short no. In alveoli. There we go. So here is an alveoli. Okay, so we need two conditions for effective gas exchange. Number one, large surface area. And the alveoli are kind of like spherical in shape. They're little circles. Circle is the best shape to have the largest surface area while having the smallest volume. You want that. You want to pack as much area in the lungs as possible without taking up too much space. So large surface area, that's good. Already satisfy the condition. Number two is you have to have a moist surface. Moist surface. You need to allow the gas from the air to dissolve into these moist layer before going into the blood. And so in order for that to happen, there is a film of water. Okay? Just like moisture that is in the inside of the alveoli. I should put some H2O here. And that is to satisfy this condition. Now, we don't want it to be like, drowning in water, obviously, then we cannot breathe, we suffocate and die. But, a little bit of moisture is needed. So in, last semester or in chemistry, do you remember a special property of water molecules? Like, if you put water molecules close to each other, what do they do?
Polar molecule.
Yeah, they're polar, right? The fact that they're polar means they're attracted to each other. So when you have all these water molecules on the inside of the alveoli, they actually create an attraction force. Okay. So H2O molecules are attracted to each other, creating surface tension. Okay. So that means the alveoli will kind of collapse, right? It will get pulled together because of the water attraction. So do you think this surface tension is going to help with breathing in, or is it going to help with breathing out?
Breathing out?
That's right. The surface tension helps with exhalation because it's like squeezing the air out, right? But interferes with inhalation. Okay. Like too much surface tension makes it difficult to inhale. Think about blowing into a balloon, right? There's some resistance. You need to blow hard to make the balloon big, right? It's kind of like that. The surface tension have this elasticity that prevents inhalation, but it helps with exhalation. So obviously, we have to have a way to counteract these things. And so there are some cells here, some special cells. These are called septal cells. Secrete something called surfactant, which is an oily substance. I'm sure you know oil and water, they don't mix together. So it secretes a surfactant, and the surfactant is going to break some of these surface tension. Okay. So surfactant breaks some surface tension. And helps with, what does it help with? If you break the surface tension, what would be easier to do now?
Inhaling.
Yeah, it will help with the inhalation, but interferes with exhalation. Okay. So I don't want you to think of them as like one is good, one is bad. It's not like that, okay? It's all about balance. By having the right ratio, a little bit of both, then breathing in and out is relatively effortless, right? So that's it. Questions? Now there is a condition that's called infant respiratory distress syndrome. Right? The baby, if it's born prematurely, then what happens is the baby would not have make their own surfactant yet. Okay, if the baby comes out too early, they don't have the lung is not mature enough to make its own surfactant yet. And so what happens is the surface tension is too great, and the baby doesn't have the strength to breathe in on their own. So they are going to be a little bit bluish because they can't get enough oxygen into the body, right? And so they need to be given a shot of a steroid, right? Just up the nose, I think. And then they inhale that. And the steroid, of course, is like lipid, right? So it will help open up their lungs and they will be able to breathe, okay? Until when they're mature enough, then they can make their own, okay?
Professor, I have a question.
Sure.
So, and this infant respiratory distress, the lung itself, bluish, or the baby?
Oh, the baby, the skin of the
baby.
baby is
Okay.
bluish because not enough oxygen, right?
Okay.
Yeah, yeah. But I mean, like nowadays they would know. Like if the baby is born too early, then right away the baby would be given the steroid immediately. Okay, so like not gonna have a problem with it. Okay, which of the following is not protected by cartilage? Okay, so it'd be a simple question. Not protected by cartilage. Remember, the cartilage keeps them open. Without the cartilage, they will collapse. They will close. And obviously, we don't want them to close, right?
Vincent, so when they collapse, is it like dangerous?
Yeah. When they collapse, you would have, like, I mean, they don't all collapse. If they all collapse, then you can't breathe. Like, just like the person's gonna die, right? But like, if a good percentage of them collapse, then you will have difficulty breathing. Right? So a person having an asthma attack, you see them like gasping for air, like like that, right? Like, and then the wheezing sound, that's because of the bronchioles collapsing. So with the bronchodilators, opens it up almost immediately. Okay. So the answer is E, okay? E is the one that does not have the cartilage. Okay, let's talk about the lungs a little bit. And for that, we will, let me see what's better. You know, I think maybe it's better if we draw our own. Okay? I mean, yeah, there's the diagram, but then there are some things I wanna tell you as well. Okay, so here let's quickly draw the lungs. Okay, so you have the trachea here. Trachea. Okay, if you want, you can put some rings on it, and then it will split, right? Into the left and right. Primary bronchus, primary or main bronchus. And then it will continue to branch inside the lungs. So we know that already. Right? That's not the focus of this diagram. Okay, so here we're gonna draw the lungs. Now the right lung, which is the left side of the diagram, the right lung actually has 3 lobes. And there is the superior lobe, the one on top. There is the inferior lobe, and the one in the middle is just called middle lobe. I guess we don't need the primary bronchus. Okay, it's kind of in the way. I'm just gonna erase that. Okay, but know that this is the primary bronchus. And then for the right lung, for the left lung rather, for the left lung, this is right lung. Right lung. And then for the left lung, there are only 2 lobes. Okay? It actually kind of makes a little space here. It's not as big because you need to put the heart there, right? So this one only has 2 lobes. There is the superior lobe and there is the inferior lobe. Okay. It's very spongy, lots of airspace inside, and you can compress it, and you can squeeze out the air, for example. So this next part is not to scale, okay? Like the size is not as big as I'm gonna draw it, but it's just easier to draw it that way. So here I'm gonna ask you to take a highlighter and go around the lungs like that if you can. Just outline the lungs. Okay, I'm just gonna do it on one side. It's the same on the other, okay? There's one line right here. Outline it. Now that is a layer that goes around the entire lung, and it's touching the lung. So it's called the visceral pleura. Visceral pleura. You might remember the heart, right? The heart has the pericardium, which also has a visceral layer, right? Now, do you remember what we call the outer layer? What's the adjective, I guess, or like a better word? There's another layer right here.
Epicardium?
Okay, that's a good try.
The myocardium.
No, yeah. I mean, for the heart, right? For the heart, there's the pericardium, but there's the visceral layer, and then there's the
Parietal.
yeah, that's the one. That's the one. Okay, so this is the parietal pleura. Okay. Okay, so the parietal pleura is stuck to the inside of the chest. Okay, or the diaphragm. I'm going to draw the diaphragm for you. This is the diaphragm, okay? Diaphragm at the bottom. There you go. So at the bottom, it's stuck to the diaphragm, and then on the side, it's stuck to the inside of the chest, okay? Inside of the chest. Now you probably can guess this. Sorry, go ahead. Someone wanted to say something?
Yeah, you mean inside the chest, I mean chest bones?
Yeah, like
ribs?
the ribs, exactly.
Oh.
Very good. Okay, you probably can guess there is some fluid, right? In between, just like the heart situation, there's some fluid here. This fluid is called the pericardial. Sorry, that was for the heart. We're talking about the lungs now. This is called the pleural fluid. And it's very important because number one, it reduces friction. As your lung expand and contract, the visceral and the parietal pleura is gonna rub against each other, and you want to reduce the friction so it doesn't hurt. But more importantly, it's wet, okay? Creates surface tension. That allows the pleura, the plural for pleura is pleurae, okay? One pleura, two pleurae, okay? So it allows the pleurae to stick to each other. I guess this the easiest way for you to visualize this is like this, okay? Listen, okay? A paper bag, okay? Like those plastic bags, the ones from the supermarket, okay? Like they don't stick to each other, right? Normally, right? But if it's wet, then they will stick to each other. Right? You understand that that analogy? It's basically like that. By putting a little bit of fluid between the two layers, now they can stick to each other. Stick to each other is very important, as you will see, when it comes to breathing. You need the two layers to stick together. If they don't stick together, you cannot breathe. Right? We're going to talk about breathing in a second.
Vincent, what layers are sticking together?
The blue and the orange, okay? The parietal, oh my goodness. The parietal pleura is gonna stick to the other one. It's gonna stick to the visceral layer, pleura, okay? I should probably write a little note for the visceral pleura here. Visceral pleura is directly attached to the lungs. All right. Are we done copying? Anything you want to ask? Okay.
Professor, is there any fluid between the visceral and the parietal? Because
Yeah.
if they are not attached, there is no sound, or
Okay.
what
Yeah. So
happens if there is no
no
fluid?
fluid. Yeah. So if this is the fluid. Okay. If there's no fluid, first of all, it will hurt because over time, when you breathing, the two layers rub against each other, and that creates friction, right? And then wear and tear. It's gonna maybe damage and hurt. Number two, it actually will you will not be able to breathe too well, right? I have to teach you about how breathing works first before you can understand why the two layers need to stick together. So keep that in mind for now. Is there such thing as too much fluid? Not too much fluid. When they say, okay, so sometimes people say they have fluid in the lungs. That's not what they're talking about. When they say fluid in the lung, that they're not talking about the pleural fluid. They're talking about fluid literally inside the lung, like in the alveoli and stuff like that, right? That could happen in like high altitude sickness. If people go up to a high altitude without acclimatizing, and then their fluid in the blood literally oozes out, and people get fluid in the lung. Is that why you're asking, or am I totally misunderstanding you, Jackie? Okay. Hopefully that.
The two branches are they the main bronchioles?
Yes. Let me label for you. It was just getting too busy. That's why I took it. Like, it was just the diagram was just too busy. But yeah, this is primary or main bronchus. Okay, and then inside the lung, it will continue to branch, right? Secondary, tertiary, and form like the upside down tree, right? All right. I hope that is good. So that's basically what we talked about with the, 3 lobes on the left, on the right, and then 2 lobes on the left. This is everything I told you about. I'm not gonna read it again. All right, the visceral is in direct contact with the lungs. I'm reading it again, okay, but you can read it on your own. It's basically the same information I gave you as we were taking the notes, okay? There's literally no new information here. All right, this is just another picture to show you what it looks like. So this is the lung over here, and immediately outside of the lung, like this pale purple layer, that's the visceral. And then we have the parietal, the pleural fluid in between, and then we have the parietal pleura, and then this is like the inside of the chest, Okay, I know it says pleural cavity here, but the cavity is filled with fluid. Okay, so pleural fluid is fine, and this is basically what we drew. Okay. Now we're going to talk about how breathing works, but first let's understand different factors that could affect airflow. All right, so we're going to look at 4 factors. Did you guys learn about Boyle's law in chemistry? I never remember like whether you learned it in first semester or second semester. Boyle's law, anybody? Yeah, okay, good. So basically, Boyle's law means at constant temperature, the pressure is gonna be inversely related to the volume, which basically means if you increase volume, then the pressure is gonna drop, and if you decrease volume, then the pressure is gonna go up. But temperature has to be constant. When it comes to breathing in and out, the temperature inside the body is the same. It's 37 degrees. So by changing the volume, we can change the pressure. That's Boyle's law. Number 2, pressure gradient. A gradient is a difference between 2 points. So if there is a pressure difference, things will, air will go from high pressure to low pressure. Okay, just like diffusion, high to low concentration. But here we're talking about pressure. Fluid, meaning air, gas, or liquid, they will always go from high pressure to low pressure. Now, the 2 pressure that we are interested in comparing when it comes to breathing is the atmospheric pressure, PA. atmospheric pressure. That's the pressure of the surrounding, the pressure of the atmosphere, right? Pressure in the surrounding. Right, so like at sea level, the pressure is like 1 atm. That's like the unit, right? There are different ways to measure pressure. We're not going to worry about the unit. Okay. In blood pressure, right, we talk about mmHg. But for like air pressure, we use atm as a unit. Okay, so at sea level is 1 atm, 1 atmospheric pressure. The other pressure we're interested in is called the intrapulmonary pressure, or PI. This is basically pressure in the lungs. Okay, again, I'm oversimplifying things here, but that's what you have to know. So tell me, if PA is bigger than PI, sorry, Leah, you had something you want to ask? I saw you unmute for a second there.
It was an accident, sorry.
Oh, okay, no worries. So if PA is bigger than PI, do we breathe in or do we breathe out? Please think about that. If the atmospheric pressure outside is greater than the pressure in the lungs, does air come in or does air go out?
Come in.
Yeah, air comes in, right? So this is breathe in. Breathe in. On the other hand, if PA is less than PI, then we breathe out. Oh, not enough space. Breathe out. Okay. Keep that in mind. We'll talk more about it in just a moment. So those are the two factors for now. There are two other factors that will affect airflow. I'm just giving you time to copy everything. Next factor is called compliance. Compliance is the expandability of the lungs. Like how easy is it for the lungs to expand? When we breathe in, the lungs need to expand to accommodate the air, right? To take in the air. So how expandable are the lungs? Well, that's related to the amount of surfactant. Surfactant is the oily stuff that the cell secretes, right, to break the surface tension. The more surface tension you break, the more compliant the lungs are gonna be. Okay, so like a balloon here, a balloon has high compliance. It's easily expandable. Expandable. Okay. Something like a water bottle, it has low compliance. It does not expand very well. Okay. You cannot blow air into it and expect it to, like, expand. It doesn't work. So we want our lungs to have a reasonable level of compliance. Finally, resistance to airflow, which is related to the diameter of airway. Basically, smaller diameter equals to higher resistance, which means it is going to be more difficult to breathe. So these pictures here shows you when someone has an asthma attack, the airway constrict, and there are all these mucus that are being secreted. So together, they make the airway very, very small, very difficult to breathe. Now, I want to ask you a question to see what you think. Okay. So let's take a deep breath. Okay, let's breathe in like that. Okay, inhale, right? Inhale deeply. So you guys already chose the answer. I haven't even asked the question yet. Let me just restart that. Okay. Let's take a deep breath. Okay, inhale. You feel your chest going up? You feel your chest going up, right? So here's my question. What happens first? Did your chest go up first and then the air goes in? Or does the air go in first and then your chest goes out? Right, so I give you two choices. A, right, air goes in first. Right, or B, chest moves up first. Right, which one happens first? Right? Take a deep breath and see. Right? Feel your chest moving. Which one happens first? Okay, very good. Anyone else before I close the poll? All right, so here's the class results. Right? Most of you think air goes in first and then the chest move out, right? Like it's very you know obvious, right? It almost seems like what do you mean? Look, breathe in and then the chest goes out, right? But actually, I'll tell you now that the chest movement is a requirement for the air to move in. If your chest can move, then you actually cannot get the air in. So the chest has to move first before there are any air movements. Okay? So I'm going to try to explain that to you in the next note. Okay? And hopefully you'll be convinced after that. All right, so back to here. Okay, we'll say this is mechanism. Mechanism for breathing. Like how does breathing occur basically? Okay. The movement of the chest and the diaphragm create the necessary conditions for air to move into or out of the lungs. Okay. Now explain how that happens. Okay, let's start with inhalation. Now this diagram is an exaggeration, okay? Like this is not to scale. Okay? This is very exaggerated to help you remember it, okay? All right, so this is the person. In order for you to breathe in, your chest, your rib cage, must move out and up. the chest, okay, really, I'm talking about the rib cage, moves out and up. Now your diaphragm is right here, okay? Your diaphragm is right here. And it has two shapes. Okay? It can be dome shape like this or flat. Okay? When it's dome shape, I'll write this down for you. Okay? When it's dome shape, it is relaxed form. When you contract the diaphragm, it goes down and becomes flat. Right? So when you breathe in, the diaphragm has to become flat. When you breathe out, then it goes dome shape. Breathe in, breathe out. Yeah? So we're talking about breathing in right now, inhalation. So at the same time that the chest is moving out and up, your diaphragm has to move down. Right, so here, diaphragm contracts, flattens, and moves down. Now, don't forget, stuck to the chest, where's my mouse? Okay, stuck to the chest and the diaphragm is what layer? What layer is stuck to the chest and the diaphragm?
Parietal pleura.
That's right, the parietal pleura, right? The blue layer here, right? So when your chest moves out, the parietal pleura moves with it. But we have the pleural fluid, which causes the visceral layer to be glued to the parietal layer. So when the chest moves out, you actually will pull the visceral layer, which means you will pull the lungs along with it. So collectively, these two actions, the chest movement as well as the diaphragm movement, both of them will cause the lung to expand. Okay, so over here, I guess I should say like this is 1 and 1. These happens together. And then number 2, the lung volume increases. Right? Because the diaphragm and the chest wall is pulling the lungs with it. It gets bigger. And lung pressure, what happens to the lung pressure? If we increase the volume, what happens to the pressure? Does it also increase or does it decrease?
Decrease.
That's right, because of Boyle's law, right? Because of Boyle's law. And so number three, when the lung pressure drops below atmospheric pressure, air rushes in and we inhale. So in other words, if you cannot move your chest, you cannot change the lung volume. If you cannot change the lung volume, you cannot drop the pressure, and then the air will not come in. All right, so you heard about people trapped under like rubbles of collapsed building or something, right? Like if there's something heavy on their chest, like a slab of concrete that's resting on their chest, they can't breathe because they cannot move the chest. They don't have the strength to move the chest to lift that heavy piece of concrete. And then they suffocate, right? You guys know like the snake, right? It's called the boa constrictor, right? So the boa constrictor Like if it catches like, I don't know, like a rabbit or something. This is kind of big rabbit. But every time the prey, the rabbit in this case, breathes out, the boa would squeeze a little harder and then squeeze a little harder. Essentially, it doesn't allow the prey to expand the chest. Without expanding the chest, they can't breathe in, right? And that's how they kill their prey, right? So hopefully you understand why the movement has to precede the air movement. Okay, so for exhalation now. Exhalation. Right. So I guess here I'll put the air goes into the lungs. Oops, through the nose. Now for exhalation, it is the other way around. And again, this is exaggeration. You can probably write the whole thing yourself. Right? Number one, the chest moves in and down. Okay. This probably should be the same color. Is it this one? Whatever, close enough. And at the same time, the diaphragm is going to go back up. Diaphragm relaxes, resumes dome shape. Now together, the action of the chest and the diaphragm will cause the lung to be compressed. All right, so lung volume decrease, lung pressure increases. Finally, when PI is greater than PA, air moves out of the lungs. We exhale. That's it. That's all for breathing. Any questions? All right. So that's what it looks like, right, with the diagram. It's pretty much what we talked about. And you can study the diagram yourself. And so earlier, right, like Myriad, you were asking what happens if we don't have the pleural fluid. Well, without the pleural fluid, your lungs will not be tethered to the chest or the diaphragm. So your chest will move and diaphragm will move, but then the lungs will not move with it. And you won't be able to breathe in or out in that case. All right, quickly here. Go ahead.
Vincent, so people with lung cancer, what in I know it's like cell mutation and everything. So what part of the lungs is having issues when they have like is it the breathing?
Say that one more time. Did you say musician? Sorry, I just couldn't didn't catch the whole question. Maybe one more time, if you don't mind, please.
Okay, I'm asking about people with lung cancer.
Oh, lung cancer. Yes, yes, yes.
Yeah, so I know it's that like that cell mutations, right?
Mutation, cell mutation. Yeah.
Yeah. So what part is it like they can't breathe, or is the lung not working?
So in the case of lung cancer, is that the lung tissue itself, like the actual lung, starts to have these growth, right, in it, these tumor growing in it, and eventually it will kind of overtake the entire lung, and therefore compromise the function. But it's it's not that they can't breathe, but it's that they have these cancerous growth in the lung that could eventually damage the actual anatomy of the lungs, right? So it is possible to remove part of the lung, though, right? Like see on the right side has 3 lobes, right? So people, if they're quote lucky enough, then the cancer is only at a specific lobe of the lung, say at the inferior lobe, then they could just cut that part off, and hopefully, it will cure the cancer in that case.
Thank you.
Yeah. Okay. Which of the following is anatomically correct? What do you guys think? Okay, not a lot of action going on here. That's fine. Which of the following is anatomically correct? First, the visceral pleura is superficial to the parietal pleura. That is not true, right? It's deeper than. It's inside, right? The visceral is inside of the parietal. The trachea is posterior to the esophagus. That's not true. It's anterior. It's in front of it. The diaphragm is superior to the lungs. Nope, it's inferior. It's below it. And the lungs are lateral to the heart. That's the correct one. All right. Which of the following statement is true? Increased volume will increase pressure as well if temperature is constant. Nope. Increased volume means decreased pressure if temperature is constant. Increased lung compliance will make it easier to inhale. That is true. Compliance is the expandability of the lungs. Reducing air diameter will increase resistance. Air will naturally flow from high pressure to low pressure. Okay. I think we should take a break. All right, just 5 minutes, and then we'll do more. Okay. We'll come back at 1:45. See you in a bit. All right, next, let's talk about breathing at high altitude and why that is difficult or impossible if you're high enough. Right, so here we go. Let's say this is sea level, okay? Sea level. And then this is the person. Now, what creates pressure is basically the air above us. If that's hard for you to visualize because you cannot see the air, think about in a swimming pool. The deeper you dive, the more pressure you feel because of all the water above you pushing you down, right? So that's the same thing on land, but except for having water pushing down on you, you have the atmosphere, the air pushing you down. So let's say at sea level, I am totally making the numbers up, okay, to help you understand. The numbers are not important, the concept is. So let's say the atmospheric pressure is whatever, let's just say, 100 units. That means in order for you to breathe in, what must your lung pressure be? Should it be higher than 100, equal to 100, or less than 100 for you to breathe in at sea level?
Less than
Less than 100.
Yeah, less than 100. So I'm going to make up a number. I'm going to say 60, okay? So you're going to have to move your chest out. You're going to have to move the diaphragm down, expand your lung, drop the pressure to, say, 60, and then the air will come in. Right? So here we have a difference of about 40, right? So let's say we take the person and then we'll put them up here now. Okay, put it up here. Now there's less air above the person now because we are higher up in altitude, right? So the atmospheric pressure here is going to be, say, 70. So if you are breathing the same way you were at sea level, expanding your lungs the same amount, by the same amount, then the pressure is going to be 60. And now it's more difficult to get air into your system because the difference is smaller, right? And also, when you're higher up in the altitude, there's less air available, less oxygen available in the air as well. At sea level, we have about 21% oxygen. Up higher up in the mountains, for example, the oxygen content is also lower, right? Because the air is thinner, right? So not only are you getting less air in your system, but there's also less oxygen in those air that you're breathing, and that's why it is difficult to breathe at high altitude. So how come we can breathe in an airplane? Well, the cabinet in the airplane is pressurized so that it's a similar pressure as on the ground. That's why we can breathe normally. But if there is some kind of leak in the airplane or something, like recently you saw on the news, or it's very scary, right? Boeing, the whole door blew out, right? So suddenly the pressure would drop very quickly inside the cabinet, and it would drop so much that you might not be able to breathe, and then you would have to wear these masks. Right? The mask would keep the pressure, and you will still be able to breathe like relatively normally. Okay, so there you have it, breathing at a high altitude. Okay, the urge to breathe. You have a part in the brain, in the brainstem specifically, called the medulla oblongata. Medulla oblongata. You will learn more about this thing later on in the course. But medulla oblongata has a respiratory center in it. And its job is to detect carbon dioxide as well as hydrogen ion, both of which is used as an indicator to trigger breathing. Right? So the more carbon dioxide you have in the system, the more of an urge you have to breathe, which kind of makes sense because then we produce carbon dioxide constantly, right? From cellular respiration. C6H12O6 plus 6O2 produces 6 carbon dioxide and 6 water, right? You learned that last semester in metabolism. And what happens to these carbon dioxide? Well, some will stay in the blood, and the carbon dioxide will actually combine with the water to form H2CO3. And then the H2CO3 can actually form H plus and HCO3 negative. I mean, you don't have to memorize any of these, but I'm trying to show you that carbon dioxide and H plus, they are related to each other. Right? So it's not the lack of oxygen that's driving you to breathe. It's too much carbon dioxide in the blood that's causing you to have the urge to breathe. So here's something you can try on your own if you want to. How long do you think you can hold your breath for? Anybody? Like roughly, do you have a number for me? Like a typical person, how long can you hold your breath for? No? Nobody? I don't know. Typically, people can hold their breath for like, 30 seconds or 45 seconds, depending on, whether you do exercise regularly or like, maybe you swim a lot or something, right? So here's something you can try. Right? You can time yourself to see how long you can hold your breath for. So when you hold your breath, not breathing out, then the carbon dioxide is not leaving your body, right? So the moment you hold your breath, the carbon dioxide level is going to slowly go up, slowly go up, slowly go up. And then there is going to be some threshold level. This is threshold. So once the carbon dioxide level hits the threshold, then your brainstem, your medulla oblongata will force you to breathe. You cannot hold on to it indefinitely, right? Okay, eventually you're going to have to go exhale and then breathe. And then as soon as you exhale, then the carbon dioxide level is going to come back down, and then you can hold your breath again. All right? And then this is what you can do. I don't know. Let's say this is whatever, like 30 seconds or something, okay? And then you can try it again. But before you hold your breath, you can breathe deeper. Like inhale and then breathe out as much as you can. And then inhale and then exhale. You can do it 10 times. Okay. And on the 10th times that you inhale, you can hold your breath. And then you can time again. You can almost double your original breath holding limit. And the reason that's possible is because by breathing out deeply, you actually help breathe out more carbon dioxide than you normally would. So your starting carbon dioxide level is going to be even lower. And when you hold your breath, it's going to take a longer time for you to climb and get up to the threshold. Right? So like maybe 60 seconds. Okay? So this shows you it is the carbon dioxide level that causes a person to have the urge to breathe. The center is not affected directly by low oxygen level. There is something else that does it. Okay? There's something called the carotid body, which is found in the carotid artery, the one that goes up to the head, right? As well as the aorta. That's going to be detecting oxygen, but that's more like a backup. Right? Just everyday function, it's the carbon dioxide that causes you to want to breathe. But when you are in a situation where you're really not breathing for whatever reason, then the carotid body is going to kick in and say, we really need to breathe now. And there's like not enough oxygen. We have to breathe. So voluntary override will only go so far. Right? You might have heard a story where there are like very stubborn kids. They say, I'm going to hold my breath unless you give me whatever, chicken nuggets or something. I don't know. So they can hold their breath and hold their breath. And in fact, what happens is they could hold it to a point where they actually pass out. But as soon as they passes out, then the brain, the breathing center, would take over. Right? As soon as the voluntary inhibition is not there, your brain will take over, and then they will start breathing again. And that's true for not just kids, for all of us. As soon as we pass out, our body will start breathing for us. So back to this situation with holding the breath, right? Some like, I don't know if you've seen those videos where people do like deep diving, deep free diving, they call it. Right? There is one version of it is that they go down as deep as they can, and then they have to get like a flag or something, and then they have to come back up, right? And they go really, really deep, like hundreds of meters down sometimes. Okay, and all the while they have to hold their breath, right? So what happens is there is like a Netflix documentary on this. I'll post a trailer for you to see if you're interested. And what happens is the person who's trying to break these world records, they go really deep, but they push beyond their body's limit and they pass out underwater. And what's the first thing you do when you pass out? Well, I just told you, you will inhale and breathe, right? But of course, if you're underwater and you start breathing, then you are breathing in water, right? And that could result in drowning, of course. Okay, we're gonna talk about this next thing, breathing volume. Right? I think the best way for you to learn this is to do the breathing pattern with me. Okay, and it just helps you remember it a little bit more. So, for example, when you are sitting there listening to me talk for the last hour and a half, your breathing pattern should be pretty constant. Okay, unless you're walking around or whatever. But if you're sitting there just watching the lecture, your breathing pattern is very normal, very predictable. Your lung expand, contract, expand, contract. So you're inhaling, exhaling, inhaling, exhaling. So this volume here that you are inhaling and exhaling, this is called the tidal volume. The tidal volume. Okay, it's just going up and down in a predictable manner. Now, suppose at the end of your inhalation, you breathe in as much as you can. Okay, so like all the way until you cannot breathe in anymore. That extra bit of air that you just breathe in, that's called the inspiratory reserve volume. Inspiratory reserve volume. Okay. Similarly, if you breathe out as much as you can, all the way until you can't breathe out anymore, there's nothing that will come out. That extra bit of air that you just breathe out, that's called the expiratory reserve volume. Okay, never mind these things. You don't have to know these things. So are we okay? Tidal volume is just going up and down normally. If you breathe in extra as much as you can, that's inspiratory reserve volume. If you breathe out as much as you can, expiratory reserve volume. And we can check this by pinching the nose and breathing into one of these tubes. Tubes is hooked up to a detector. It's called spirometer. Okay. So that's expiratory tidal volume and inspiratory reserve volume. Now, if you exhale as much as you can, right, all the way out, then you are at this point, right? Exhale as much as you can. From that point, if you breathe in all the way until you cannot breathe in anymore, then you have basically gone through the expiratory reserve volume, tidal volume, and inspiratory reserve volume. And together, all these things, it is called the vital capacity. Vital capacity. That's essentially, the maximum volume you can move in and out of your lungs voluntarily. Okay. Does anybody have any question about the terms, the four terms? So basically, vital capacity equals to IRV, inspiratory reserve volume, plus tidal volume, plus expiratory reserve volume. Questions? All right. But even after you breathe out as much as you can, right, the lung volume is not zero. There are still some air that's inside the lungs, and you will never be able to get those out voluntarily. That air that's left behind is called the residual volume. Residual volume. We also call this the dead air. The dead air is very high in CO2. It does not engage in gas exchange. That's why it's called dead air. It's useless. Right? It's no good. There's too much carbon dioxide in there. It's not gonna help us with anything. Okay? So we don't want to have too much dead air. We don't want to have too much residual volume in our lungs. Okay. The more residual volume we have, the less efficient our lungs are gonna be. Okay. Questions? The amount of air that could be voluntarily expelled at the end of each respiratory cycle. What is that? The extra amount of air that you can breathe out as much as you can. What do we call that volume? Okay, the correct answer is the expiratory reserve volume. How about this? Remember, that is the formula. So vital capacity is 6,000. We don't know IRV. Tidal volume is 500. Expiratory reserve volume is 1,000. So that's IRV plus 1,500 equals 6,000. You can subtract 15,000 from both sides, and you will get 4,500. So there will be a similar calculation for the test. Okay. We're just gonna wrap it up with talking about smoking. Tobacco is the only legal consumer product that kills half of its regular user. And you think about that statement, that's pretty crazy, right? If I say, you know, every time you use your vacuum cleaner, there is a 50% chance you're gonna die from it, then no one's gonna use the vacuum, right? But that's exactly what it is with tobacco. Even though it kills so many, half of its regular users, people continue to do it. Globally, cigarette smoking kills 4 million people each year, and about 70% of the deaths occur in developing countries. Non-smokers will also be affected because of secondhand smoke. You don't have to be standing next to a smoking person to be inhaling secondhand smoke. If you can smell it, then you are inhaling secondhand smoke. The smoke can be soaked up into clothing, into furnitures, and even lingers in the room long after the smokers has gone. Right? That's why Ontario, they banned smoking while you're in a car with a minor. And at one point, people were allowed to smoke at a restaurant, but not anymore. This graph just shows you the prevalence of tobacco use in male. And you can see the darker the color means the more people smoke in those places. And it's very prevalent in some of the developing countries. And similar pattern for female. Overall, more male tend to smoke than female. but in terms of distribution of where they smoke, it's a little bit different. You can see here for men, you know, the prevalence is concentrated in developing countries, but for female, it tends to be in some of the developed countries. So, you know, there's some interesting stat there. Okay, effects of smoking on respiratory system. There's not going to be a lot of questions on these things. So rather than taking a note, I'm just going to talk to you about it. Lungs of non-smoker and a smoker. Over here, we have the non-smoker and we have the smoker on the right side. And all these black stuff are basically the tar that's from the cigarette smoke that you're inhaling. And also, in addition to tar, there is also buildup of chemicals, carcinogen. Here, I'll write buildup of chemicals that are carcinogen or mutagens. Carcinogens are things that will cause cancer. Mutagens are things that will cause mutations. If a person accumulate enough mutations, then it could lead to cancer as well. Okay, so that's a not good looking lungs. And other thing that could happen with smoking is the cigarette smoke is going to paralyze the cilia. Okay, paralyze and damage cilia. Paralyze and damage cilia. And you can see in this picture on the left side, it's a non-smoker bronchi, very nice looking cilia. And on the right side, like a whole patch is gone, right? So what happens with missing cilia is the person no longer has the mechanism to remove some of these trapped particles in the lungs. The only way for them to get it out is by coughing it out. So you can see a lot of heavy smoker, they cough a lot and then they spit out things, right? That is smoker's cough. Okay. And the person is also more prone to infection, allergies, and yeah, and asthma. Okay. Because they don't have a way to clear out the airway, right? So you know, if there's pathogens that are stuck in the airway, they're going to be able to colonize. Without the cilia, you know, there's a whole empty patch there. They would attach and infect. The pollutants, the allergens, all these things can stay in the airway, triggering allergies and asthma. This is irreversible. Once the cilia are gone, they don't come back. Now there's something called asbestos. That's what they look like. And asbestos is used as a fire retardant. Used as a fire retardant. It slows down the spread of fire in building. It's found in a lot of like older buildings. They don't use that anymore because they found out asbestos cause a very specific type of lung cancer called mesothelioma. Right? This is the lung with the mesothelioma, and it's very potent. This stuff. Right? The story goes as this: it used to be the people who goes into the mine, they get exposed to asbestos, and their family also have mesothelioma just from the exposure of the miner's clothing. Okay, so even not like a direct exposure, like an indirect exposure is also going to be able to trigger to cause this particular form of lung cancer. Now, I mean, when smoking was a thing, it was done as almost like a leisure thing for people to do, and it's like you know, like a pastime thing to do. Okay, people didn't think much about it. They didn't think that it would be like you know, negative health effect. And when the scientific community and the medical community starts to publish these data and saying, you know, maybe smoking is not after all, it's not a good thing. Right? It's going to cause lung cancer and other health problems. Then the tobacco company were not too happy because it, you know, take away their profits, right? And so what happens is there's this particular product, a brand. They say, you know, all over America, more scientists and educators smoke Kent, the brand, with the micronite filter, right? They are claiming that the filter that they have on their cigarettes will take away the bad stuff, so you can enjoy smoking without worrying about the adverse health effect, right? And it turns out that the filter that they make actually contains asbestos, right? So maybe you're not going to be getting the cancer from the cigarette, but you know, the asbestos will certainly give you the mesothelioma, right? So nowadays they have a lot of measures to try to discourage people from smoking. You know, on the package they have all these pictures that shows you what happens, right? When you smoke, what happens to your gum, to your teeth, and then, you know, cancerous pictures of tumors and stuff like that. And I think the latest one that they came out, that the Trudeau government came out, is that the individual cigarettes have labels on it now. Right? It says it's like poison or something like that, right? And that is supposed to stop people from smoking. Personally, I don't know. I don't think it's gonna stop people. Like, I mean, if people are already smoking, right, they're not gonna care if the stick says, you know, poison on it, right? I think it's an empty gesture. It doesn't really have much of an effect. But anyway, that's that.
I have a question, Professor.
Yeah.
So, most of as the picture showed, most of educators, for example, the doctors,
Yeah.
they have like more knowledge about it, but they are
No, I know, right? Yeah, so people
yeah,
smoke for all
but
kinds of reasons, right?
yeah,
Yeah, they do. Like even doctors, they smoke.
yes,
But you know, I don't know why they do, but they do, right? Maybe it's stressful, right? I don't know. It's hard to quit, I'll tell you that, right? I know some people who smokes and they try to quit, and it's not an easy thing, right? Even after they quit, there's always that craving. And you probably will learn a little bit about why that is the case when you learn about the brain, right? So that's that. Now, emphysema, that's another thing. Okay? Emphysema is another problem that occurs in long-term smokers. But smoking is not the only reason to cause emphysema. There are other causes as well. Okay? But emphysema is basically loss of elasticity in lungs. Okay? The smoking will kill the alveoli and leave behind these big pockets, right? Big empty pockets. When the alveoli die, they leave behind these big empty pockets. So that will increase, this will increase the residual volume. Remember, residual volume is dead air, right? Dead air. They have a lot of carbon dioxide in them, and they do not participate in gas exchange. So when your lung lost the elasticity, it doesn't empty itself as much, right? Instead of like blowing into a balloon and you let go, the air comes out automatically, pretty much, right? In emphysema, it's like blowing air into a paper bag. You blow air into a paper bag, you can leave the paper bag alone, the air just kind of lingers inside, right? It doesn't come out automatically. What's the difference between paper bag and the balloon? Well, the balloon has elasticity to it, right? It's elastic. The paper bag, not so much. So that's what emphysema is. Loss of elasticity, right? So you don't empty your lungs and the air stays in the lung and it reduces your gas exchange capacity, okay? Now, if a person has emphysema plus chronic means ongoing, bronchitis, okay? So bronchitis is the inflammation of the bronchi. So together, these two things, there is a condition called COPD, right? Chronic obstructive pulmonary disease, right? It doesn't matter what it stands for, okay, COPD. But when you see people carry an oxygen tank with them, right, to breathe, right, with the tube and everything, that's COPD. They can't breathe on their own. Their lung capacity is so compromised, and along with the inflammation, makes it very difficult for them to breathe on their own. And so they carry the oxygen tank to up the oxygen content, right, to help them.
So, Vincent, is there any other factor besides smoking to cause like this emphysema?
Yeah. So a person could be have like a very serious lung infection that could left them with emphysema. There are other conditions like, you know, cystic fibrosis that damages the lung, that could also have similar effects. Okay, so it's not just smoking. Yeah. All right, pneumothorax. Pneumothorax is what happens when the lung collapses. This could be because of a light knife wound. That's probably the most common type. But it's also possible, like in a car accident, the collision force is so strong, it causes the rib to break, and the rib stabs into the lungs, and you pop the lungs. Okay, so this picture shows what happens when one side of the lung collapses and the other side is still okay. So like you can still breathe, but it hurts a lot. The other side hurts a lot. Okay, I know two people, two friends of mine. Both of them had pneumothorax, and they say the pain is like, you know, unbelievable, right? Because like the lungs is basically not opening, right? And you know, you can't talk and stuff like that. And what they need to do is obviously go to the hospital, and they would insert a tube here into the deflated lung. They would pump air in to open it up, and basically wait for the lung to heal. Okay, and then they will be okay again. Sometimes it could happen spontaneously. Okay? For my friends, it was spontaneous. They didn't have any stab wound. It wasn't a car accident. It just, one of them just woke up one morning with a collapsed lung. Okay, I forgot how the other one got it, but you know, one reason for that is sometimes you have these things called cysts that can grow on organs. Right? They could go on the lung, they could grow in the uterus and the ovary and the kidneys. They could grow anywhere. And the cysts have fluid inside, and sometimes they might even have like hair and teeth inside. It's for real, okay? Like you can look it up. So these cysts can grow anywhere, and sometimes they pop. Right? When they get too big, they pop. And popping the cyst can also lead to the lungs to collapse, and you know, pneumothorax. Right? So sudden onset of chest pain, shortness of breath, need medical attention right away. Carbon monoxide poisoning. Carbon monoxide is colorless, odorless, and tasteless, and it's poisonous. That's why everybody needs to have a carbon monoxide detector at home. If you have one at home, you should put it close to where you sleep. Don't put it in the kitchen, because the cooking fumes and stuff like that can mess with its function. Right? Put it where you sleep. Carbon monoxide is poisonous because it binds to hemoglobin. Hemoglobin is the protein that transports oxygen for you. But when there's a choice between carbon monoxide and oxygen, the hemoglobin will always bind to the carbon monoxide. And so you are not able to distribute oxygen effectively in the body. And it could lead to nauseation, breathlessness, dizziness, right? And you feel like tired and headache and all that stuff, right? Which is dangerous if you're home alone and you have carbon monoxide poisoning and you don't have a detector. Most people, if they have a headache and they feel dizzy at home, they take the Tylenol and then they go to sleep, right? But if it's actually carbon monoxide causing this, then you might die in the sleep. That's why you need a detector. What are some possible sources of carbon monoxide from your home?
Gas leak. Furnace.
Okay, so I heard gas leak. Gas leak is not so much because they actually add some smell to the gas to know that there is a gas leak, right? Okay, and the carbon monoxide is not in the gas. But good try. What's the other one? Sorry.
I told in the furnace when.
Yeah, the furnace. Okay, so when the furnace is functioning properly, it should be okay. Right? Carbon monoxide is generated when you have combustion reaction that is happening in low oxygen environment. Okay, so that leads to incomplete combustion. So you generate carbon dioxide, water, but there is also carbon monoxide in the process. Right? So like a malfunctioning furnace can do that. And if people try to burn things indoor, that could also generate carbon monoxide. I remember, I don't know, like almost 7, 8 years, even 10 years ago, maybe, there was a blackout in Toronto. Right? That winter was particularly, cold, and there's no electricity for like 3 days. And people brought their barbecue propane burner inside and turn it on to keep them warm or to cook. And then they actually die from carbon monoxide exposure. Okay. Another source of carbon monoxide is the car. Right? You should never leave your car running in the garage. Right? All that exhaust can build up the carbon dioxide level and cause a person to be poisoned by it. That is all. Okay, that's everything I need to teach you for Unit 1. I checked the eCentennial. A lot of you have not done the lab yet, so I don't think it's useful for me to take it up. I will post the answer for the lab though. You should try it on your own first, the PowerPoint slides. Okay, and then I'll post the answer for you to check. We will meet again next Tuesday on the 4th, and I will take up the review package with you. Okay, I've already posted the review for test number 1. It should be in the announcement, but let me just double check to make sure. Just give me a second, guys. Okay, so that's the online lab. Again, a lot of you haven't clicked it yet, so I assume you haven't had a chance to work on it yet. So you work on that. I'll post the answer for you to check. There's the lab quiz that you can do. There will be 2 attempts, and only the best one will be recorded. And you have until next Thursday to complete it, so no rush. There is the review package. Okay, so work on that between now and Tuesday, and then we will take it up on Tuesday. Okay, taking up the package should take most of the class. But if you have additional questions from the study guide that you want to go through, make sure you let me know. Send me an email. Say I want you to take this up in the review, and then I will. Okay, and then that's it. Tuesday will be the last class with me. No class next Thursday. You just do the test. And then the following week, Miran will take over for the rest of the course. Okay, that's it. Enjoy the rest of your week. Take care, guys. Bye-bye.
Thank you.
Yeah.
No problem.